Welcome, colleagues. In today's Explainer, we're stepping right back into the consulting room to really dissect the craft of individual psychotherapy. If you want to refine your understanding of the incredible nuances within the healing relationship between therapist and patient, you are absolutely in the right place. I'm going to guide you through a comprehensive masterclass drawing heavily from core psychodynamic principles so we can unpack exactly how we facilitate true, lasting clinical change.
So, let's tackle a classic piece of clinical lore right out of the gate. For decades, this maxim guided therapists. Be as expressive as you can be and as supportive as you have to be. The implication here is pretty clear, right? It suggests that uncovering unconscious conflicts, the expressive work, is somehow inherently superior to just bolstering a patient's defenses. But modern research, specifically from the Menninger Foundation's Psychotherapy research project, completely dismantles that myth. We now know for a fact that clinical changes achieved through supportive elements are in no way inferior to those achieved through expressive ones. They're just different.
Here is our roadmap for this masterclass. We'll start with the expressive supportive continuum, then move into your core clinical interventions, transference and resistance, mechanisms of clinical change, matching therapy to patients, and finally, brief therapy and termination.
All right, part 1, the expressive supportive continuum.
We're going to start by breaking down the historical divide between these two approaches. You've got expressive therapy on one side, which is geared toward analyzing defenses and diving into the transference. On the other side, you have supportive therapy, oriented towards suppressing unconscious conflict and bolstering those defenses. But here's the reality check for anyone doing this work. Pure versions of these therapies rarely exist anywhere in actual clinical practice. As an effective dynamic therapist, you aren't just picking a lane and rigidly sticking to it. Instead, you're constantly shifting back and forth along this continuum, depending entirely on the immediate needs of your patient's ego at any given moment.
Moving right into part 2, your core clinical interventions.
So, how do we actually navigate this continuum when we're sitting with a patient? Well, here is your primary toolkit. Moving from the highly expressive interventions at the top down to the highly supportive ones at the bottom, we go from interpretation and observation, down through clarification and empathetic validation, all the way to advice and praise. Let's look at how these two extreme ends actually operate in the room. Let's look at the highly expressive end first. Imagine saying to a patient, "Maybe you feel you have to disagree with my observations because I remind you so much of your dad." This brilliantly illustrates an interpretation. You're making an unconscious linkage conscious. The patient isn't just disagreeing with you, they're reacting to you as if you were their father. You're taking a present, defensive behavior and linking it directly to its unconscious origin, right there in the moment. It's incredibly powerful when timed right. Now flip over to the completely opposite end of the continuum. Consider this real-world exchange. A 52-year-old mother was utterly consumed by guilt over her teenage daughter's out-of-wedlock pregnancy. She was entirely unable to function. Her psychiatrist, acting very supportively, pointed out that she was taking on responsibility that literally wasn't hers. When she asked him, "You mean I didn't spread her legs?" the doctor directly and firmly affirmed, "That's right, you didn't spread her legs." He used his authority, giving advice and praise essentially, not to uncover some deep hidden truth, but to rapidly rebuild her adaptive defenses and immediately absolve her of a crushing, inappropriate guilt. That brings us to part 3, transference and resistance. Let's see how all this builds into the essential bread and butter work of our daily practice. Look, before you even think about interpreting a defense, you absolutely must establish a working alliance. This is a rational, relatively non-conflictual rapport where the patient collaborates productively with you. It's you and the patient teaming up against the problem. Extensive research shows that the strength of this therapeutic alliance is arguably the single most robust predictor of a positive clinical outcome. You are directly aligning with the healthy, functioning aspects of the patient's ego to achieve your shared goals. And of course, once you build that alliance, what happens? Resistance shows up. It's inevitable. But as seasoned therapists, we don't look at this as just stubborn, willful defiance. We have to look at it with deep clinical curiosity. A transference resistance is a characterological defense that's emerging to protect the self. For example, a patient might stay totally silent in a session because they're unconsciously assuming you're going to judge them, just as a hypercritical parent once did. They are clinging to an internal object relationship to feel safe.
Next up, part 4, mechanisms of clinical change.
So the million-dollar question is, how does all this intricate interaction actually make the patient better? Enter Menninger's triangle of insight. This beautiful model captures the process of working through. Essentially, we track recurrent patterns across 3 distinct domains of the patient's life: past relationships, current relationships outside the therapy room, and the immediate transference relationship happening right there in the room with you. Our job is to help the patient see the invisible thread connecting all three corners of this triangle.
Let me ground this with a classic clinical vignette. Take Mr. B, a military man who came into therapy complaining that he was too domineering in his marriages. In one session, he casually mentioned arguing with a softball umpire, saying, "You don't argue with the umpire, what he says goes." Later on, he described his father as an arbitrary military man he could never negotiate with. Finally, he passively accepted the therapist's arbitrary 12-session limit, assuming the therapist's word was absolute law. The therapist elegantly linked all three corners: the umpire, the domineering father, and the therapist himself. He showed Mr. B that to master the trauma of being dominated as a child, he was actively dominating his own wives. That right there is insight in action.
But hey, insight is only half the story, right? People change in other ways too. Beyond those brilliant, perfectly timed interpretations, we also have implicit relational knowing. Sometimes, simply experiencing a new, engaged, and safe attachment relationship physically restructures the patient's implicit procedural memory. It's those unscripted, spontaneous moments of mutual recognition, a shared look, a profound moment of empathy, that provide a corrective emotional experience completely outside the realm of formal technique.
Which leads us to Part 5, Matching Therapy to Patients.
Having a masterful grasp of your interventions is completely useless if you apply them to the wrong person. Patient selection is absolutely critical. For instance, a patient with strong motivation, a high tolerance for frustration, and an intact capacity for reality testing, they are primed and ready for expressive work. Conversely, if you have someone with significant ego defects, poor impulse control, or someone going through a severe, acute life crisis, they require a solid supportive bedrock. If you push highly expressive, uncovering techniques on an already overwhelmed ego, you seriously risk causing a harmful regression.
We've also got to assess their underlying psychic structure. Research broadly indicates two types of patients who change in very different ways. First, you have introjective patients. They're highly ideational, preoccupied with establishing their self-concept. They want to understand themselves intellectually, and they respond incredibly well to insight and interpretation. Then you have analytic patients. They are primarily concerned with relatedness and connection. They're going to gain much more therapeutic value from the healing quality of the relationship itself than from any clever interpretation you could offer.
Finally, Part 6, Brief Therapy and Termination. Let's talk about the constraints of time. If you're doing brief therapy, say 10 to 24 sessions, you literally do not have the luxury of open-ended free association. You have to be sharply targeted. The absolute necessity here is identifying a core dynamic focus within the very first or second session. You've got to formulate your central hypothesis quickly, and you're going to start interpreting resistances much earlier than you ever would in a long-term analysis.
As we look at concluding a treatment, or even planning its trajectory from day one, what really dictates our final course of action? It is dangerously easy for us as clinicians to become a bit paternalistic. We might prescribe what we think the patient needs, like a fundamental restructuring of their entire personality, rather than listening to what they actually want, which might just be assistance with one specific situational complaint.
I want to leave you with this somewhat provocative thought attributed to Freud. In the end, the patient is always right. We can offer our expertise, our vast continuum of interventions, and our deep understanding of the unconscious. But lasting clinical change only happens when the patient is an active, willing collaborator in the process. So, the next time a patient staunchly resists your absolute most brilliant interpretation, ask yourself, are they failing to understand you, or are you failing to understand what they actually need in this exact moment?